Good evening, everyone, and I welcome you all for this Tuesday webinars. What we are doing since last 2 years, we try to get some interesting topic every Tuesday with from Yashoda Hospital, group of hospital in association with ICCM Hyderabad City branch. So, what yet another interesting topic for today to discuss, that is plex or plasma exchange in acute liver failure, which is coming up in a big way. If you see the guidelines also changing, initially it was in grade 2A, now it is grade 1A indication when it comes to plasma exchange in acute liver failure patients in different form of liver failure and all. Now slowly the plasma exchange role is like expanding day by day. To discuss on the same thing, we have three expert panelists, Dr. Santosh and Dr. Somsekhar Rao and Dr. Naveen. All three of them are very senior gastroenterologists and hepatologists, renowned hepatologists and gastroenterologists in the city. So we are fortunate to have all three of them today as panelists so that we can have a clear-cut idea when and what to do in a case of liver failure, when to start plasma exchange, when not to, how far the evidences suggest to start. To go through to have a simple idea when and how and what to be done in acute liver failure patient and what is the role of plasma exchange. We have Dr. Vishnu Vardhan. He is a senior consultant critical care at Yashoda Hospital, High Tech City. So initially, Dr. Vishnu Vardhan will present at least to have some initial idea about plasma exchange role when it comes to acute liver failure. Then we'll go to the panelist. We can discuss few things, and in the meantime, the attendees can post their questions in the Q&A section so that we can later or in between, if it is relevant, we can take those questions. With that, I thank each and every panelist to take out their time and to join this webinar, sir. And thank you very much. And over to you, Dr. Vishnu. You can start off your presentation.
Thank you, Mishra. Good evening, everyone. So today we'll discuss about plex in acute liver failure. So coming to the definition of acute liver failure, so it refers to the development of acute liver injury with impaired synthetic functions, that is INR greater than 1.5, and having altered mental status in a patient without previous cirrhosis or a pre-existing liver disease. So commonly, we use a cutoff of less than 26 weeks to define as acute liver failure from the onset of encephalopathy. So anything about 26 weeks, we call it as a chronic liver failure. So it is a syndrome of diverse etiology, and the mortality is very high in these patients. It's approximately around 50 to 90%. So, and following liver transplant most probably improves the survival of these patients. So there are many causes for this acute liver failure. In India, it is mostly because of the viral hepatitis like A, B, C, D, E, herpes simplex and cytomegaloviruses and chickenpox. So in Western side, it's more of because of acetaminophen. So antitubercular drugs and other recreational drugs can also cause us this thing. So coming to toxins like carbon tetrachloride, phosphorus, and all these things are also causes of acute liver failure. Coming to some pregnancy, alpha fetoprotein and HELP syndromes and acute fatty liver of pregnancy. So they can also present with acute liver failure. So others include like Wilson's and autoimmune and some carcinomas and lymphomas. So this in acute liver failure, there will be progressive derangement of hepatic synthesis and metabolic dysfunction, which leads to wide varied symptoms like severe coagulopathy, jaundice, renal failure, worsening encephalopathy, and metabolic dysfunctions. All this worsens the mortality of these patients. So when there is a liver failure, so the synthesis, metabolization, and detoxification decreases. As a result, there will be accumulation of vasoactive toxins, both albumin bound and water soluble, These toxins in turn causes severe cerebral, circulatory, and renal dysfunction along with immune dysfunction, which presents with moderate symptoms and causes mortality of these patients. So now we discuss, after going to the brief discuss how this therapeutic plasma exchange helps these patients. So actually, therapeutic plasma exchange initially is usually it requires for various other acute or chronic life-threatening medical conditions. ASCO and AABB, there are various medical conditions along with the evidence for the use of these AFRCs. So the clinical indications for therapeutic plasma exchange have been progressively growing. Although the clinical efficiency of this TP has been documented with randomized control study only in limited number of diseases. So coming to TP in hepatic failure, so it helps in removal of both, as I already told, albumin-bound and NW toxins, including ammonia endotoxins and mercaptans, which are responsible for hepatic COPA and hyperkinetic syndrome that occurs in the acute liver failure. And TP also helps improving the patient's cerebral blood flow, mean arterial pressure, cerebral perfusion pressure, and cerebral metabolic rate. So increased hepatic blood flow and improvements in other laboratory parameters such as cholinesterase activity or galactose capacity. So TP may also restore hemostasis by providing coagulation factors and removing activated clotting factors, TPA, fibrins, and FDPs. So coming to TP in acute liver failure. So in some patients, liver may recover during TP, and in other patients, failure may persist, necessitating liver transplant. So aggressive TP has been used as a bridge to liver transplant in few cases. So in a large case series, TP has shown to decrease the cytokine activity, so which are generally seen as important for the CIRS response in these patients, helping in recovery of these patients. The same thing when there is an hepatic injury or death, so it produces dams, so which in turn causes activation of the macrophages and monocyte activation, leading to production of many pro-inflammatory cytokines or mediators, CD64, TNF, and IL-6, and all those things, which in turn causes increased inflammation and tissue damage. This high-volume plasma exchange helps in removal of these dams and removal of all these inflammatory mediators, so helping in hepatic regeneration and decreasing the tissue destruction. So as we know, there are no controlled randomized trials. So only one trial was there. So where they compared, it is a randomized trial which is done by Larson and et al. So using high volume plasma exchange in patients with acute liver failure. So many of the studies are these are our post case cohorts and only comparing only few. This is the largest randomized control trial we are going to discuss. So in this study, it is a prospective multi-centric randomized control trial. So in this, they randomized almost 182 patients with acute liver failure, out of which half of them are receiving the standard medical therapy, and the rest are receiving standard medical therapy along with high volume plasma exchange. So in this, in high volume plasma exchange, so they try to replace approximately 15% of the ideal body weight of the plasma, or at least 8 to 10 liters of plasma per session, which helps in removal of almost 90 to 98% of the toxins. They have maximum of 3 sessions, or they have done till the improvement of the liver or till the patient underwent a transplant. So in this, the primary endpoint was they tried to find out that liver transplant-free survival during the hospital stay, and second endpoint including survival after liver transplant with or without high volume plasma with intention to treat analysis. So these are the demographic characteristics of these two groups. So they are almost similar in both the groups, like gender, age, weight, and cause for the whether it is acute, hyperacute, and all those demographics were similar in these both groups. So therapeutic plasma exchange has been shown to reduce levels of, I already told you, the decrease inflammatory cytokinins. So not only improving the hemodynamics, but also improve transplant-free survival and acute liver failure. When compared with standard medical therapy, high volume therapeutic plasma exchange improved mean arterial pressure and reduction in vasopressor requirement. And these patients requiring fewer renal replacement therapies. And it has shown to decrease ammonia levels and improving the grades of hepatic encephalopathy. And there is a significant improvement in transplant-free survival with no difference in outcome between paracetamol or non-paracetamol etiology of acute liver failure. In subgroup analysis, so high volume therapeutic plasma exchange was shown to improve survival among patients that are not listed in the transplant. And there are no significant survival benefits in patients who received high volume therapeutic plasma exchange as bridge to transplant. So coming to this Kaplan-Meier curve, so intention to treat analysis and patients fulfilling transplant criteria that received high volume plasma exchange. So there is increase in the survival benefits when compared to the standard mortality rate. So we'll discuss about the results. For the entire patient population, the overall hospital survival was around 58.7 for patients undergone high volume plasma, and it is around 47.8% for the control group. So hazard ratios with and confidence interval of 0.36 with P of 0.08. So, and high volume plasma prior to transplant did not improve survival compared with patients who received standard medical therapy alone. So the incidence of severe adverse events was similar in two groups. SIRS and SOFA scores fell in the treated group compared to the control group. Coming to one more study, this is done in the Department of Christian Medical College. So here they compared low volume plasma exchange and low dose steroids. So they improved survival in patients with alcoholic related acute and chronic liver failure and severe alcoholic hepatitis. So we'll discuss, this study has been done in our CMC Vellore by Kumar and Georg. In this background, so coming to this background, alcohol-related acute and chronic liver patients. So these patients have high short-term mortality and are poor candidate for steroid therapy. Plasma exchange improved survival in these patients. They showed low volume plex. In this low volume plex, it means it's around 1.5 liters of the plasma was exchanged in these patients, and a low dose steroids, approximately methylprednisolone of 20 milligrams has been used in these patients. So they retrospectively compared the efficacy of low volume plex and steroids with standard medical therapy. So that were treated between November 2017 to June 2019. And the primary study outcome was 1 year survival. So out of these, 21 patients are in the plex group. So, and in the standard medical group, there were around 29 patients. So all the 50 studied patients had a severe alcohol hepatitis with a Madrid discriminating factor score of 84.7. So in the plex group, patient had a minimum of 3. So it varied between 1 to 7 plex sessions. So with 1.5 liter of plasma exchange per session and methylprednisolone around 20 milligram per day, tapered over 1 month. Same thing, they are screened about 250 patients and they excluded 200 patients that are having infection rate and all those things. They finally included 50 patients. They have taken 21 patients in the plex and 29 patients in the standard medical therapy. The demographics are more or less same in both the groups. So the primary study outcome, survival over 1 year in these patients with plex and SMT group. So intention to treat analysis and per protocol analysis. The patients who underwent the plex had a higher chance of recovery and survival. Secondary study outcomes, response to plex with the patients, these patients with renal failure. So there were actually the patients who are undergone plex, there was a recovery in the renal dysfunction as well. Out of 10 patients, 6 patients, the renal function has been normalized. So coming to the limitations of the study, it is a retrospective design. The small number of patients were studied and the patients lost to follow up in this. So they have not used the ACLS specific disease severity scores like ARC score to categorize the study patients. And the study design does not permit us to discern if steroids or plex or the combination improve the survival. So in this preliminary report compared to SMT, so low volume plex and low dose steroids improved survival, 1 year survival in alcoholic acute on chronic liver failure patients with severe alcohol hepatitis and patients with renal dysfunction. 60% showed improvement in the renal function with plex. Studies with a larger number of patients are need to validate these results. And one more study, Abdogan. So they compare the effect of total plasma exchange and fulminant hepatic failure. So in this, before TP and after TP, they compared. So there is almost 54% survival benefit in 21 patients, out of which 12 underwent liver transplant. So in these patients after plex, there were significant improvement in the coagulopathy, hyperbilirubinemia, and hyperammonemia levels. So coming to the guidelines, where to use high volume plasma therapeutic apheresis. The ASFA has in the 7 special issues has recommended so therapeutic plasma exchange in acute liver failure as a grade 3, category and grade 2B. So in patients with acute liver failure with high volume plasma exchange, the grade is almost category 1 and grade 1A. The recommendation is grade 1A. So AFSA has recommended as a high volume therapeutic plasma exchange as first line therapy for acute liver failure and permanent Wilson's disease. It also recommends that to perform at least minimum of 3 cycles procedures daily and to consider perform daily treatments until the liver transplant or the liver recovery. But in fulminant Wilson disease, they recommended only standard volume plasma exchange treatments until liver transplant or the liver recovery is recommended. So coming to in 2016, the European Association for the Study of Liver Disease recommended high volume therapeutic plasma exchange level 1 grade 1 evidence in acute liver failure, but they have not done any recommendations on acute and chronic liver failure. So in 2011, American Association for the Study of Liver Disease guidelines suggested plasma exchange means to acutely lower serum copper and limit copper mediated kidney damage in Wilsonian acute liver failure while waiting liver transplant. But however, they have not, no recommendations were made for the general use of this therapeutic plasma exchange in acute liver failure and acute and chronic liver failure. So summary. So coming to the summary of all these things, therapeutic plasma exchange is a useful technique in the prevention of complications in the setting of acute liver failure. So because in plasma exchange, we use both FFP and albumin. So there is a correction of coagulopathy is possible without volume overload and with production of renal function. So however, therapeutic plasma exchange is not a replacement for definitive therapy for the liver failure. So most of the cases, they require still the definitive therapy is liver transplant. But it can be used where the transplant is contraindicated. This can be used as a rescue therapy for them to require, or they can we can do therapeutic plasma exchange as a bridge to transplant. High volume plasma apheresis has demonstrated statistically significant benefit in transplant-free survival and acute liver failure. So further refinement of target population and adequate endpoints and optimization of plasma exchange is required. So the therapeutic plasma exchange to be integrated in standard medical therapy for a specific subgroup of acute liver failure and acute and chronic liver failure.
Yeah. Thank you, Vishnu. I think it was a nice overview of all the guidelines and how to go about in acute liver failure patient and the roles of plex. So Somsekhar sir, good evening. Your mic is off, sir.
Yeah. Yes, sir.
I think the theory part is over. We need to discuss now the practical part.
Yeah. Right.
I think
I agree. See, we have gone through the presentation, very nicely presented by Dr. Vishnu. So, see, the American guidelines, American AASLD guidelines were of 2011, which says there is no role for plasma exchange, but maybe they will be changing this year or next year. What we are looking at is definitely not all patients with ALF would require liver transplantation. So it is a very, very dicey situation where we may not be able to differentiate these patients, whom to go list for transplantation, whom not to. But any patient with acute liver failure and meeting King's College criteria, we definitely list them for transplantation. But all these patients may not have a living donor immediately. The liver may not be ready. In these patients, definitely we should definitely try and start them with plasma exchange initially. And as Vishnu has mentioned, at least 3 sessions of plasma exchange may bring benefit. I can't say the number because we don't have any trials to say, but in many patients, they may recover actually. And we have a direct experience in acute on chronic liver failure. We have been doing plasma exchange in lot of patients with severe alcoholic hepatitis who present with acute on chronic liver failure. And maybe in the last 1 year, we have seen at least 80% of them improving with just 2 or 3 sessions of plasma exchange. So definite experience in acute on chronic liver failure, I can definitely say, but selecting the patients is very, very important. All these patients, either in acute liver failure or acute on chronic liver failure, they may be having superadded infections. That is the most important thing where we have to exclude all these patients with severe infections, or before definitely doing a plasma exchange, we definitely need to exclude or treat all the infections. So the results of plasma exchange are definitely a lot better. In, for example, with the standard medical treatment for acute on chronic liver failure or severe alcoholic hepatitis, we were using steroids, and most of them do very badly with steroids because of superadded infections or flare up of any existing infections. So most of them we were discontinuing steroids. But with plasma exchange, we are seeing very good results in acute on chronic liver failure. Acute liver failure, my experience is not very big for plasma exchange, but definitely when people are improving in severe alcoholic hepatitis, acute on chronic liver failure, there is all possibility that we should be trying at least 3 sessions of plasma exchange in all patients in acute liver failure, and we should be listing them for liver transplant definitely, but there is all possibility that they may improve and come out of acute liver failure.
so in your practice, sir, how many of these acute liver failure patients where like they are fulfilling the criteria for liver transplant when they underwent this plasma exchange because of maybe the liver is not a thing that you can get it immediately? How many of them where they didn't require liver transplant ultimately by plasma exchange?
That is what I'm saying. In acute liver failure, frankly speaking, in acute liver failure patients, we did not do any plasma exchange, but my experience is limited to acute on chronic liver failure.
Okay, sir.
So acute liver failure, recently Dr. Naveen had a patient, I think he will talk about it, where patient has, there's no necessity for transplantation, and the patient has come out of acute liver failure actually.
Sir, actually, Dr. Vishnu has told many times regarding high volume versus low volume plasma exchange.
Yeah.
I think the data is supporting in favor of high volume plasma exchange.
High volume. we are also looking at high volume plasma exchange in at least acute on chronic liver failure. High volume plasma exchange has definitely helped.
So what exactly, sir? How many plasma volume we remove when it comes to high volume, and
Around 8 to 10 liters is high volume plasma exchange in one
with
session.
one
In
session?
one, yeah,
So very big volume what we are trying to do.
exactly. Lot of plasma, lot of plasma.
Because in regular plasma exchange, what we try to remove is around 3 to 4 liter at maximum.
Yeah, but we are getting good results when we are doing at least 6 to 7 to 8 liters actually, and we need a good support from the blood bank.
Sir, what is your experience of like plasma exchange in this acute fatty liver of pregnancy, sir? Like because those patients they come very sick, and they are also
Definitely, sir.
present.
Acute fatty liver of pregnancy is almost ALF, but we have not tried any plasma exchange. At least I did not try any plasma exchange in these patients. My experience as of today is lot. I can say maybe in the last 1 year we have done somewhere around 30 plasma exchanges in acute acute on chronic liver failure, severe alcoholic hepatitis.
There we have seen a significant improvement, isn't it, sir?
Significant improvement, sir. The standard treatment mortality, 28 days mortality is around 60% with the standard medical treatment. I'm talking exclusively of severe alcoholic hepatitis, sir. But with the addition of plasma exchange, what we have observed is more than 80% are surviving. I can say they are improving actually. And the mortality has come down to maybe less than 10%,
Sir,
28-day mortality.
do you have any experience or any idea about different form of acute liver failure in different poisonings like aluminum phosphate, yellow phosphorus, and all?
Most of the time we see rat poisoning, sir. That's the only poisoning what we see going into acute liver failure. And
What is
it will not.
is there any like studies in all these things, sir? Because in India, maybe these things are more common compared to Western countries.
Yeah.
So-
So see, the data on Plex is actually coming up recently for the last 2 years for acute liver failure. So we have not tried any at this point of time for acute liver failure, but definitely I can say if we can support the liver for few days with plasma exchange, maybe we will be able to avoid few transplantations with the newer improvement in Plex and all these things.
Sir, just one interesting part. If you see, like in ASPA guideline 2019, in ASPA guideline 2019, they told this plasma exchange. They didn't mention it to be how high volume or low volume.
Yeah.
Categorize it as grade category 3. Category 3
Yes.
where the improvement or these things are not very well known.
Yeah.
So category 4 will be harmful. Category 1 and 2 will be like 1, it is
Very sure.
100%
Yeah.
effective. And category 3 where it is the things are not clear. But now so many guidelines are coming up one after one where it is they are categorized as like grade 1A indication. Why this change, sir? Like any like significant data
I
is
feel
supposed.
maybe the volume of transfusions has increased, which has improved the outcomes, is what I feel. So as you said, the standard plasma exchange was maximum 3 liters because we were worried about volume overload most of the time. So now with the increased volume of plasma exchange, results are good actually. So slowly the guidelines have changed once the results have come up very well.
Dr. Naveen has joined. Dr. Naveen, can you hear us?
Hello. Yeah, hi. I can hear you now. Good evening.
Good evening, sir. I welcome you. I welcome you, sir, for the session. Actually, Dr. Somsekhar sir was telling about your experience when it comes to this few cases of acute liver failure, where we believe they were fitting into the criteria for liver transplant. but we could avoid liver transplant by doing plasma exchange. Can you just share your experience, sir?
Yeah, I think primarily these patients are ones who had actually severe alcoholic hepatitis-related ACLFs. Those are the majority, the bulk of the patients that where we actually could see benefit with the plasma exchange, and we could avoid the transplants. So I think the idea is with the plasma exchanges is first important thing is you need to make sure that there is inflammation going on, but at the same time there is no sepsis. If there is no sepsis on board for these patients, then you do plasma exchange for these patients. And we had at least, I would say, at least 5 to 6 patients where they were listed for a transplant, liver transplant, but we wanted to give a try with the plasma exchange. So that's one group. Alcoholic hepatitis is one group of patients. The second group is a dengue hepatitis, dengue-related hemorrhagic syndrome, dengue-related shock syndrome, where they had ALFs because of dengue. Even in those patients, we could actually help out with plasma exchange. Is the rat poisoning patients. So there we had a significant improvement with the plasma exchange for these patients. So 3 group of patients where plasma exchange has been helpful, and certainly these patients have been listed for transplant or super urgent listing, particularly the rat poisoning cases, where with doing plasma exchange, we're able to off-list them from the transplant.
Interesting, sir. Actually, one thing which is going on right now, maybe we are all in Hyderabad or let it be in India, that is dengue. We are seeing a lot of severe dengue nowadays where the liver functions and all are significantly affected. Their enzymes are coming in like thousands. I've seen people having 11,000, 14,000 enzymes also. Actually, these people, one more trend what we have seen is, not in every case, but when we have sent ferritin and all those things, ferritin came out to be very high. Even in few cases when we have thought of HLH and we have done a bone marrow biopsy and sent those few biomarkers for HLH, those are also came out to be positive. Do you believe like maybe because of HLH and this liver dysfunction combined together, there is a like not a clear-cut role of plasma exchange when it comes to HLH? Apart from steroid, there are some studies where HLH also is being helped with plasma exchange. Because whenever we believe in a dengue patient, there is a liver dysfunction, they must be having other organ functions also must be deteriorated. They usually in the multiple organ dysfunction, one of the organ which is affected in dengue is more commonly liver is being affected. But do you believe that's maybe one of the reason why these things might have improved?
Yeah, it could be possible. See, these patients are in a lot of MODS, isn't it? Shock syndrome. So doing plasma exchange indirectly helps all these conditions, including the HLH also. So what I'm trying to say is even dengue patients with severe shock syndrome, where they have dengue hepatitis related, we're able to retrieve them with the plasma exchange. But as I said, those are small proportion of patients. Majority bulk of patients is from the alcoholic hepatitis related ACLFs. So with alcoholic-related hepatitis, we generally start with, we do different scoring systems like Maddrey score, Glasgow alcoholic hepatitis score, and also the MELD scores. So if that scores are very high and there is no evidence of sepsis, then we start them on steroids, and we do what we call Lilly score a week later to see how they respond. Is a steroid responder or non-responder? If it is a steroid non-responder, and there's no evidence of sepsis, then those are the patients where if they have coagulopathy and bilirubin is very high, we're talking about 30s and 40s, then for those patients, plasma exchange has been a big boon.
A very interesting concept, sir. Welcome, Dr. Santosh, I think joined just now. So basically, sir, want to ask like, I think Dr. Somsekhar sir has told already, on an average, how many cycles they are requiring and how frequently we are doing plasma exchange in these cases? Dr. Santosh or Dr. Naveen, anyone?
Yeah, Santosh, are you there? Shall I answer this? On an average, we are doing about 3 to 4 cycles, and we'll reassess the things. That's been the standard. 3-4 cycles of plasma exchange. We generally do, if at all fluid overload, of course, we do low volume, but otherwise we tend to do high volume plasma exchange. That's the standard of care. 3 to 4 cycles, and then reassess things. But there are patients who actually had benefit only after giving 7 or 8 cycles. Okay, so but 3 or 4 cycles is generally the standard that we actually, when we counsel a patient, we say we need to give at least 3 to 4 cycles till we see the response to it. See, once you do the plasma exchange, bilirubin comes down nicely, coagulopathy gets corrected. But the real test is 24, 48 hours later, it will start shooting up again.
So what will be your target when we should think that we can stop plasma exchange in these cases? Every
See, this is the
alternate day we do?
So this is a gray area, to be honest. The reason I said there are no clear-cut guidelines on these plasma exchange. I recently written a chapter on plasma on alcoholic hepatitis, and one of the topics which I written down was about plasma exchange in it. But even when I actually was looking for it, there were no clear-cut guidelines about how many exchanges that you need to do before you say that yes, they had a response or non-responder. But on general, what we have seen is after giving at least 4 cycles, we see the response after that. If there's a 50% improvement, then we consider that he's a responder, we continue giving it.
We look at the PTINR, coagulopathy, platelets, or
And bilirubin. Yeah, of course, the synthetic function. We look at the MEL scores and then we'll decide on it.
I think Dr. Santosh says, Dr. Santosh is there. Santosh sir, can you hear me? Sir, I think Dr. Vavan is our chairperson when it comes to ISSM Hyderabad city branch. Sir is also joined today as one of the panelists. I think he messaged that he has good amount of experience when it comes to dengue, hepatitis, and plasma exchange. Can you share your experience, sir? I think you are driving the car right now.
Yeah. Sorry if you are hearing any background noise, but I don't have much experience. But I just wanted to share one case scenario where we had the severe dengue shock syndrome, dengue severe hepatitis, and patient has gone into a multi-organ failure. So at this point of time, as a last resort, we started her on plasma exchange, even though we are not sure about the evidence at that point of time. So, but we had a very good response with the plasmapheresis. After 3 sessions, patient started improving. The vasopressor requirement came down. The bilirubin was coming down, and the patient slowly gained conscious. Eventually, we could extubate her and send her home. So I just wanted to share this experience. One patient with severe dengue hepatitis, and shock syndrome, recovering with the plex.
Thank you, sir. I think recently we have few cases where there was a liver dysfunction. They have multiple organ dysfunction in dengue, where their ferritin came out to be surprisingly very high. We have never seen a ferritin of 90,000 in any patient. Ferritin 70,000, 60,000 like that. In a few cases, we have done actually extracorporeal therapy with cytosol, and there are other extracorporeal therapies. Heme adsorption cartridges are coming from Jaffron, that is HA230, and out of 4 people, 3 people survived after doing that. There is a significant improvement. I believe there is a mechanism of maybe significant cytokine storm kind of thing, which is getting help when we do a heme adsorption. Any idea, sir? Any experience on that? Somsekar sir or Naveen sir, anyone can take this question.
Yeah, so I think the science is still evolving. We don't know what it actually maps out, but yes, we have seen a difference as well. But I exactly don't know the science behind it, how actually it helps, but we have seen a difference also in these patients.
Somsekar sir, your mic is off, sir. Somsekar sir, your mic is off. Somsekar sir, your mic is off, sir.
Yeah.
Yeah, please. You can go ahead, sir. You are telling something. Sir, one more thing, actually, is there any other form of heme adsorption therapy? Nowadays, actually, this company called Jaffron, which is a Chinese company, they are one of the leader when it comes to this heme adsorption or these cartridges and all, they have came up with two of the cartridges. I think if I am not wrong, this is HA340 and 340L or something, specifically targeting people having hyperbilirubinemia and people having this acute liver failure. Any idea about those cartridges, sir? Have you used it or any?
We have used it on patients. Yeah, we used it on a couple of patients who actually had bilirubin of more than 45. One of them was 45, another one was about 46, 47. Yeah, they like CytoSorb filters. They also help in just mopping up the bilirubin. Yes, it comes down. The problem is the bilirubin comes down, but again, it will shoot up again in next 2-3 days. So it works like a filter, but again, we have not seen a clinical benefit from it.
I think Dr. Venkat has also joined. He was, I think, a bit busy, for which I have to take over and do the moderation in the initial part at least. Dr. Venkat, you want to say something?
No, Mr. I think the discussion was on the right track. But what we have seen in the recent, I think, last decade or so, we have seen a wide spectrum of acute liver failures, including Dr. Naveen and me has seen recently with the HEPE. You remember, sir, that case with HEPE?
Yeah.
So, but what happens is we have seen some of the struggling cases where they continues to actually worsen on all medical therapy. And these cases, not just HEPA and E, but we have seen some yellow phosphorus, aluminum phosphide, and ratol, the same yellow phosphorus. So these are the poisonings which actually we had few experiences in Secunderabad unit and in Malakpet units. And we have seen a mixed report, like mixed response. A couple of them have responded, couple of them we lost. I'm not convinced enough with either of the way. I think the expert has to have their own point to say. We can actually take Dr. Vishnu, who has been a part of the transplant team with Dr. Raila and all. Vishnu, can you also share your experience?
Most of the cases we never used this Plasmax and all those things because Dharmesh Kapoor used to lead the transplant work where I work there. So he never believes in Plasmax and high volume because any patients who are having acute liver failure, he feels the transplant is the only this thing. So only we try to do plex in patients where the patients are not fit for transplant or there is non-availability and there are no other options. They try to do plasma exchange in themselves. So we never tried high volume plasma exchange. So we did only conventional plasma exchange when I worked in the transplant department.
Mr. There are some questions on the question bank related to high volume to standard volume to low volume. So any comments on that, Dr. Naveen and
See, there was one good paper from CMC Vellore, in particular to the rat poisoning. That paper was a randomized control trial actually, which I think they had about 200 odd patients in that trial, a randomized control trial between standard of care treatment versus plasma exchange. And that paper has clearly showed that a huge benefit with, I can't remember the numbers as such, but good benefit from the plasma exchange. And since then we have used plasma exchange in rat poisoning cases. As I said earlier, patients who were listed on for liver transplant, we were able to offlist them from the list because they got better with the plasma exchange treatment. So for us, that has become the standard of care. We used it on at least 3 patients that I remember, where plasma exchange has, and all these 3 patients where we actually use plasma exchange for particular rat poisoning cases, they improved without doing a transplant.
Sir, one doubt. Doubt means actually personal thing, sir. This plasma exchange when we do in this acute liver failure patients, what like as an exchange fluid we use plasma or albumin more often or only albumin?
No, plasma. We use plasma as exchange.
Because if you see the Mars or which molecular adjustment Mars and all, where it was totally albumin only.
Yeah, albumin.
So like how it is different, sir? What is the problem with albumin or why plasma scores over albumin when it comes?
Mars, there was in European they did a Mars. The Mars was actually done from UCL in London. That's where actually they started the Mars program, the trial, Julie Wenden, and the randomized control trial was stopped in between. It didn't actually complete the trial because the outcomes were poor. Okay, it didn't make any meaningful outcomes to it. That's why they had to stop the Mars. And that's why what they're doing now is they're doing further study in the European, it's a randomized control trial which is happening, multinational trial, where they're modifying the Mars and see if, so we know that albumin is a very good, not just the oncotic pressure, it has got so many other properties which actually helps in patients with the cirrhotic patients. It has got anti-immunomodulatory functions and also the scavenger functions. There's so many other functions, not just the oncotic pressure. That's why they are trying to use albumin in a different modified Mars. The trial is still running. I was told that the trial will run till 2025, probably will get published in 2026. But till then, albumin, we're using it only as CLD patients to improve the oncotic pressures and stuff. But in terms of plasma exchange, it has always been a plasma that we exchange, not the albumin. So we generally tend to give 15 to 20 plasmas for each time, and then we exchange plasma only, not the albumin.
Okay, interesting concept, sir. Because most of the time when it comes to plasma exchange in any other condition where we do, most of the time the exchange fluid what we use is albumin only. The albumin. If patient is unaffordable or there is some coagulopathy, then we try to give plasma. But rest of the time we try to do this plasma exchange in any other condition, let it be a Guillain-Barré syndrome or your other condition, myasthenia and all, we do with albumin. But here we mostly use plasma.
Yeah.
Isn't it, sir? Anything, sir? Santosh sir to add or Somsekhar sir to add?
Yeah. Regarding the same point, actually, the reason why albumin causes more problems will be when you do the only exchange of plasma and replacement with albumin, you will be taking all the clotting factors away. Obviously, the post-procedure coagulopathy will be more. So with the Plex, that part will be sorted out because whatever we are giving will have coagulopathy, coagulation factors. So from that point of view, some advantage. Adding to Naveen, actually in Derby Group UK, they persisted with the Mars for 10 years and they had extensive data. What it was showing was as long as they were on Mars, the parameters were stable. The moment you switch off, then everything went back to normal. So there was no reversibility seen in these very sick patients if they did not have any liver available. And also I wanted to add, where it cannot be used, I think probably if there is no acute detectable insult leading to the ACLF, in those cases who are presenting with a deep cholestasis but without HF and normal enzymes and all, it just will not sustain the benefits. I think those group, I feel that will not be beneficial to plasma exchange if they have only cholestasis with no HE and no detectable acute insult leading to the inflammatory pathway. This is like a post-episode cholestatic phase. I don't think this will show any benefit. If you look at the recent data, also the 50% who are not responding may fall into that group. That's where this ALF group may, if they don't get any infection, they may benefit from the plasma exchange.
If, one thing, sir, for all the audience and maybe for us also, let's see, in acute liver failure, there are clear-cut criteria like King's criteria and all when the patient should go for a liver transplant. And where you place plasma exchange, sir, in these cases, when there is acute liver failure, shall we go ahead little early or maybe before the patient landing up in acute liver failure, or we should wait till the patient is fit for a transplant? Like where you place plasma exchange when it comes to a significant acute liver dysfunction patient may or may not be in acute liver failure. Anyone can answer, sir.
I think 72 hours is the cutoff time. You wait for 72 hours, and if they are going down, that's when you should start using this.
So two things here. I think one is your ALF patients, other is your ACLF patients. Both are different categories. Okay. If we talk about ALF patients itself, there's, as you say, there are clear-cut guidelines in terms of when we should list these patients for transplant. Okay. So if the patient fits to any of the criteria for transplant, they should be listed for transplant. We should not rob away from their opportunity of getting a transplant. Okay. Whilst waiting for a transplant, for example, a typical case, as I've been telling, is rat poisoning. Okay, the rat poisoning case, they actually have coagulopathy, they got encephalopathy, they're listed for the, they fit all the criteria for transplant. You list them for a transplant. Whilst you're waiting for a transplant, you actually can start doing a plasma exchange. And one of the studies which actually said is, once you list the patient, in fact, not just this patient, once you know that the patient has got encephalopathy, early plasma exchange versus doing late plasma exchange. And benefit was always been on patients who actually started a very early stage of plasma exchange. So you list the patients, at the same time, you also consider doing a plasma exchange. And as I said, we had 3 patients where we actually could delist them from the ALF. So we should not wait, but at the same time, we should not leave the opportunity of not giving the transplant.
Like, is there any, I think Dr. Vishnu also presented some paper, like bridge to transplant. If the patient is sick enough and it is getting time, we are taking more time to get a liver. In that case, can we try plasma?
Absolutely. And these are typically patients with ACLF patients, because ALF patients, they generally get listed very quickly. Okay, there's a super urgent listing. So as long as there's an organ available, they'll get the first opportunity. Okay, but ACLF patients, they don't behave, they're not categorized the same as ALF patients. Okay, neither they are chronic patients, CLD patients, neither they're ALF patients, they're middle. Okay, so ACLF, they have not been categorized as such that there should be super urgent listing. Okay, for these patients, always there'll be a long wait for them to get a transplant. And these are the sickest patients. Okay, so these are the patients where we actually use as bridging therapy. As I said, typical of the alcoholic hepatitis who they're progressing towards the ACLF are the right ones we should actually do. And as Santosh was saying, definitely cholestasis related CLDs, we don't normally give plasma exchanges. It is only the inflammatory process, acute inflammatory process, which is causing a surge response and which activates the DAMs and the PAMs. And that's the patients where actually plasma exchange will help.
What is I think I have asked the same question to the Somsekhar sir also. Just I'm asking to have some more clarity, because like AFLP is one of the important patients, like in pregnancy, where the patients are coming with acute fatty liver of pregnancy and they deteriorate very fast. Like, do we have, actually there are some data, but is there any clear-cut data or your experience when it comes to plasma exchange and AFLP patients, sir?
See, AFLP patients, the treatment is basically delivery, isn't it? Once you know that you deliver the patient, and most of the times they recover after once you deliver the patient, the baby. Yeah, so the role of plasma exchange in these patients is limited, because the treatment, see, if it's ALF patient, you know that they need a transplant. That's a treatment. Okay. For the AFLP patients, the treatment is basically delivery. So once you deliver the baby, most of the times they settle down. You don't need to go for the transplant for these patients.
Interesting, sir. So I think we are almost at the closing time now. Any take-home message, sir? Somsekhar sir, any take-home message, like final, from all 3 of you? I want some take-home messages, so that these are the things what we should understand and everybody should keep in their mind whenever they attend a case of acute liver failure or they are suspecting the patient is worsening.
I think we should spread the message that this type of therapy is newly introduced, and there are some definite benefits to certain group of selected patients. So that if they are in the peripheral centers or somewhere where they are just waiting because they are not affordable for the transplant, we should disseminate the information that this is a new form of therapy, and then it should be taken up and considered at the earliest before they get sepsis, secondary sepsis because of the ACLF or ALF.
Somsekhar sir.
Now that we have data, so we should be doing plasma exchange in wherever it is necessary, actually, where we were not doing in many cases previously. So there is data, and it should be used as the first line management in wherever there is an indication. I agree with Dr. Santosh. This knowledge should be spread, and we need to do, in more patients. Maybe we will have more cases to do plasma exchange when we know that it is helping.
Naveen sir, anything?
Yeah, so I think adding on to the same thing, spreading the message is very important. This has definitely been I think one of the revolutions, shall I say, over the last few 2, 3, 4 years at least, that we have seen. The plasma exchange has definitely made a benefit. So people should be aware of it. That's a treatment available. Okay, but at the same time, they should also know that anybody who is sick with liver diseases, they should be referred to the highest center, so that all these treatment options. See, we will not just do plasma exchange and then wait and watch. We'll have other plan B, plan C in place. Okay, so we should keep all those things in mind. Then only we should think about plasma exchange. Yes, if there are patients who are not fit for a transplant, who doesn't want to go for transplant for various reasons, whether it's a financial or other reasons, then they will be left with plasma exchange as an option. But I think anybody who is sick with liver diseases, because they deteriorate very rapidly, they should be referred to a transplant, to a referral to a center where they can manage with all these things, all these patients. And they should keep in mind that plasma exchange is definitely a good treatment with good outcomes we have seen. So that they should also be aware of it, that there are alternatives to transplant treatments.
And need to be shifted early.
Yes,
Instead of
absolutely.
keeping them till the patient will not be in a condition to be shifting also.
Yeah.
In between, we lost few cases, similar cases, ACLF cases. Actually, I am a very pro when it comes to plasma exchange and this this adsorption therapies. And nowadays we started using more often in different kind of indications. We are seeing very good result actually. Even now they are started using plasma exchange even in sepsis and septic shock. And the data are coming up. There are more promising. Maybe in next few years we might be thinking of plasma exchange in a patient of sepsis. At this point of time, we believe by doing plasma, we are removing the immunoglobulins and all those things that can precipitate a sepsis, but maybe it is other way out. So sepsis may not be a contraindication in future. The trials are coming up. I think we had a very healthy and nice discussion. Dr. Somsekhar, Dr. Santosh, and Dr. Naveen. I think the practical points what have been added was really helpful. I think all the people who are attendees and who are going to listen to our webinar afterwards also, they are going to be helped. And the final message should be there are treatment, and we should not like stop someone getting those treatment, and you need to at least transfer the case early to a place where all these facilities are available. And this should be percolated to all the people who are treating patients who are having liver dysfunction or liver failure. Dr. Vishnu has, thank you very much, Dr. Vishnu, coming up with all those data and nicely presented overview of all the things when it comes to plasma exchange acute liver failure. I will thank each and every person to taking out time and giving their valuable suggestions and insights to this today's webinar. Thank you all, sir. We'll close the session then. Thank you all the attendees for this webinar.
Good night.
Thank you.
Thank you.
Thank you.